Right, cup of tea in hand. We're nearly there. We've nearly finished Moxham's syllabus. Good lord, we've nearly finished Moxham's syllabus. So, Vasculature 2 out of 2 now. If you were looking for core neuroanatomy and you didn't have much time, you could potentially skip this lecture because a lot of this is taking your neuroanatomy and applying it. Also, there's a bit of histology as well. So, let's begin with the haemorrhages, which you should have done to death at this point, particularly if you're a clinical medical student. So, basically, extradural or epidural, subdural, subarachnoid, and intraparenchymal or intracranial hemorrhage. Here are two examples. So, arterial blood because your middle meningeal artery has ruptured, particularly at the pterion, quite classically. The dura has two layers, and it has peeled off of the skull here. So, it has crossed this region here, and we have a lovely little shape here. Now, if you go subdurally, the dura is still attached to the skull, and venous blood, usually bridging veins, pool between this region of dura and arachnoid mater. Okay? This isn't a subarachnoid bleed. So this is an extradural and a subdural hematoma. So, the question now becomes, what do they look like on imaging? And here is what they look like. So, here is our banana shape, our classic shape here, and our lentiform shape. So this is your epidural. Epidural is your lemon, and subdural is your banana. Because your epidural, remember the dura is still adhered at the edges here, so it forms a sort of, it's like a bulge, like you're trying to peel the dura away, so it has a very uniform structure. But you're not peeling dura away. It sits below the dura. It sits between that really thick dura pinned to the ostium and the arachnoid mater. So it just sort of flops. So that's the difference here. So here is your epidural bleed, and here is your subdural bleed. Now, what we have here is quite interesting. So here we have an example of a subarachnoid and an intracranial bleed. Now this is clearly a massive intracranial bleed with mass effect. It's gone intraventricular as well. A whole load of horrors going on here. This is terrible. This is an intracranial bleed. What else can I say about this? It's within the actual brain substance itself. Okay. But this is more interesting. This is in the this is a subarachnoid bleed. So it follows the contours of our gyri, of our sulci here, and it enters the cisterns, the basal cisterns, which are in the subarachnoid space, which we're going to come to. And you have this characteristic star-shaped pattern as the ambient cistern, the interpeduncular system, and the quadrigeminal system are all together here around the midbrain region. Okay, we will come and we'll see those in more relief and more detail, but this classic star-shaped pattern occurs in a subarachnoid hemorrhage. Okay, so the subarachnoid following those contours, whereas your intracerebral is within the actual bleed itself. Your extradural bleed looks like a lemon, and your subdural bleed looks like a banana. Okay, so formation, constituent, and course of CSF. Now, we won't go into too much detail on CSF, but I do just want to mention that CSF, cerebrospinal fluid, is in this little system here. It's free-flowing, and it's supposed to be flowing unidirectionally, but it doesn't. It flows bidirectionally. It's formed in the choroid plexus of various different ventricles, and then it runs through the system. So it starts in the lateral ventricle. So here's the frontal horn, the temporal horn, and the occipital horn of the lateral ventricle, and here's the body. And then via the interventricular foramina of Monro, it comes to the third ventricle. And via the Sylvian cerebral aqueduct, it comes to the fourth ventricle. Now the fourth ventricle, whose roof is the cerebellum and the floor is the medulla oblongata, is continuous with the central canal inferiorly, but also has a few apertures through which things can escape. The lateral aperture of Luschka, there's two, and then there is a median aperture, which allows transference of the cerebrospinal fluid from fourth ventricle. So here's your cerebral aqueduct, here's your third ventricle. Allows transference of fluid from here via the median aperture into this cistern here, which is called the cisterna magna because it's next to the foramen magnum, which is here. Okay? The cisterna magna communicates around the cerebellum and bathes the cerebellum, and then comes up here to this region, which is called the quadrigeminal system. And that's because here we have the quadrigeminal plate, which is the superior and inferior colliculi. This region wraps around the midbrain to this portion. So there is a communication here. Remember, we've got a midline section. This is 3D. So actually, CSF is not only in front and behind, but it's around. So if you go around it, you make the ambient cistern. Ambient means around. To this region, which is the interpeduncular cistern, right? So here's the midbrain, the cerebral peduncles, and the interpeduncular cistern sits there. Now what's this? It's the pituitary gland region, right? So this region is called the suprasellar, because if you remember, here's the sella turcica of the sphenoid bone into which the pituitary gland sits. So you have your suprasellar cistern here, communicating the ambient cistern with the quadrigeminal system. And then ultimately, fluid continues to drain through the suprasellar system up here, up into the superior sagittal sinus via this outpouching called the arachnoid granulation. So this is still a subarachnoid space. So we have dura above it, attached to the walls and all these other kinds of things. Then we've got arachnoid mater, pia mater. This is the subarachnoid space. An outpouching of arachnoid mater into the superior sagittal sinus occurs, and the CSF will leak one way through here, into the superior sagittal sinus. So, quick recap, produced in the choroid plexus, mostly the lateral ventricle, which is here, okay, goes through third ventricle, fourth ventricle, it can go through the spinal canal or the medial and lateral foramina, and is then absorbed by these arachnoid villi into the superior sagittal sinus. These calcify as you get older. If they calcify too much, then you're going to have a blockage in the system, okay? But that can make you look like you've got little white spots on CT and chest x-ray. CT and x-ray head. It can look like you've got little spots because you've got little calcifications, okay? So make sure that this arrangement is nice and simple for you, okay? These basal cisterns here are our interpeduncular cistern, our suprasellar or chiasmatic cistern. It runs up here, subarachnoid space, and then arachnoid granulations pierce the superior sagittal sinus. And remember that our superior sagittal sinus joins the occipital and straight sinus to form the confluence of the sinuses. Okay? And here's another recap, another image if it helps you. So, third ventricle, aqueduct, fourth ventricle, out through the median aperture to the cisterna magna, which is also called the cerebellomedullary cistern, but the cisterna magna is probably easy to remember because here's the foramen magnum. You run up and around, and encasing the straight sinus here is the subarachnoid space. And here is our quadrigeminal cistern, because we have our quadrigeminal plate, we have our pineal gland, we have our fornix here, we have our massa interna, we have our choroid plexus of the third ventricle, which also secretes CSF. And then we have another septum pellucidum here. This is superimposing because remember, this is a mid-sagittal section, so we actually have just hidden away here laterally the lateral ventricle. So our quadrigeminal cistern will communicate via the ambient cistern to this region, the interpeduncular cistern. And then we have our suprasellar cistern, and this communicates up via these tiny arachnoid granulations into the superior sagittal sinus. Here's another schematic. If it helps you, you can pause here, but we will carry on now. So, you will have a neuroimaging lecture, you may have already had it, with Jamie, who is my housemate, and also happens to be the president of the Radiology Society, and he wants to be a radiologist. And he is going to talk to you about ways to systematically read CT head scans, particularly in the ED when you're time restricted. And one of the things you need to look at, the second thing you look at are the basal cisterns, which is the suprasellar cistern, the interpeduncular cistern, the ambient cistern, and the quadrigeminal cistern. Okay, so here's our internal carotid and our middle cerebral artery coming off here. Here's posterior communicating artery. Here is posterior cerebral artery. Here is the oculomotor nerve here. So remember PCOM aneurysms, knockout cranial nerve 3. Remember that. Here's your optic chiasm, optic nerve, optic tract. So a few systems to remember. Here's our quadrigeminal system because we have our colliculi, which are part of the corpora quadrigemina here. We have our ambient system, which can be divided anteriorly and posteriorly, but honestly, no. Right? So we have a quadrigeminal system, our ambient system wraps around the midbrain, interpeduncular system, suprachiasmatic system. Okay, you can also have the carotid systems either side of here, but we don't care too much about that because this is what we care about. This beautiful illustration here of the ambient systems here, the quadrigeminal systems, wrapping around to form the interpeduncular system and then the suprasellar system. Okay? Here's a lovely quadrigeminal system and the ambient system will be formed around here. The posterior ambient system, the anterior ambient system. Okay, so make sure you know these four systems. Now, CSF itself should be a straw or clear colour. CSF runs in the subarachnoid space. Okay, so scalp, we've got the 5 layers of the scalp, which if you remember is skin, connective tissue, aponeurosis epicranium, loose connective tissue, and periosteum. Okay, we have periosteum here, then we have the bone of the skull with its 2 tables and a dipole in between. Then we have the dura mater, which has 2 different layers, a periosteal layer and a meningeal layer. And it's the meningeal layer here in this weird browny colour that drops down, and in between the 2 layers of dura, that is where your sagittal sinuses are formed. Those dural venous sinuses lie between the periosteal and meningeal layer. If we continue with the meningeal layer in the superior sagittal aspect of the horizontal fissure, you have this falx cerebri, and this is in that longitudinal fissure only. But if we go a bit deeper to the meningeal layer of the dura mater, we have the arachnoid mater, which I think is purple. Is that purple? That's a really weird colour. Yeah, so we've got that little arachnoid mater here. And then underneath here in blue, like bluey turquoise, is, anyway, it's our pia mater. Okay? So this subarachnoid space here, this subarachnoid space, this subdural space, and then epidural lying along here. Okay, so that's basically what we're saying. So if we have the subarachnoid space, this is where the cisterns lie. This is the plane. They herniate through and form arachnoid granulations into the dural venous sinuses. So here's our arachnoid mater, here's our pia mater, and here's the subarachnoid space with trabeculae. CSF flows through here, up through here, and then through this invagination into the venous sinus, CSF leaks through into the sagittal sinus, the superior sagittal sinus, to go through superior sagittal sinus, confluence of the sinus, and then from the confluence of the sinus, it will go transverse sinus. From the transverse sinus, it will go into the sigmoid sinus and then the internal jugular vein. So, papilloedema, swollen optic disc. It's late stage findings of ICP. It's rare. But look at this reduced disc margin with flare hemorrhages that you see. Okay? Any worry about discs, pallor leading into papilloedema, you need to refer to ophthalmology. It's really bad. But why is papilloedema relevant here? Well, it's relevant because here's second nerve, the optic nerve, right? The optic nerve is surrounded by dura mater and a subarachnoid space, right? There's a subarachnoid space, which means the CSF. So if you have any CSF buildup, it's going to compress the optic nerve, and ultimately, like toothpaste being squeezed, you're going to get papilloedema. You're going to get bulging of this optic nerve head, the optic disc, okay? So here's our lamina cribrosa, okay, which is where all the fibres come together and leave the retina and form the optic nerve. And at this point, this will bulge when you have the blurry disc margins and you have papilloedema. So, Common examinations in CSF. So I've put together 6 things here, and very quickly we'll go through what we think. So, for bacterial meningitis, you have an increase in polymorphonuclear white blood cells. You have a decrease in glucose and an increase in pressure. Okay? So white cells are up, glucose is down. Proteins are up, pressure's up. In cerebral hemorrhage, you have what's called xanthochromia, so it's bloody to yellow. Xantho, think xantholasma, it's yellow. There's no glucose changes, and protein and pressure's up. In Guillain-Barré, it's lymphocyte rich, it's normal pressure, glucose nil, but you've got proteins. In MS, it's lymphocyte rich, because remember, inflammation, no glucose, no protein, no pressures. Okay? Spinal cord tumour, exactly the same. Viral infection, exactly the same. Okay? So these are very similar differentials, but acute bacterial meningitis, glucose tanks, white blood cells go up, proteins go up. Cerebral hemorrhage is yellow, and you increase in protein and opening pressures. Now, the blood-brain barrier. So your blood-brain barrier, here's your endothelial cells. So here's a blood vessel. Here's one of your glial cells, astrocytes, that wrap their podocytes, their end feet, around the barrier, and a tight junction is a secondary region as well. And this is all to give your brain a level of privilege that other parts of your body do not have. There are some exceptions, which are called the circumventricular organs, which have holes in their blood-brain barriers for various functional reasons. But otherwise, this is why it's a nightmare to deliver drugs into the brain, because the blood-brain barrier says nope, it's very protective. And here's another sort of image. So you've got some pericytes as well, but mostly astrocytes and endothelial cells form your blood-brain barrier. So, as we said, there are these circumventricular organs, some regions such as the area postrema. It's quite important to note. But then, and that's of the medulla. This is the region that I think we'll come to in a minute, but it's to do with the sort of like the vomiting cardiorespiratory regions. We have the pineal gland here, the subcommissural organ, don't worry too much about that, and the subvorsal organ. There's this region here, which is called the organum vasculosum of the lamina terminalis, and then the pituitary gland, the posterior pituitary gland. All of these functions, all of these things, either secrete something, so need holes to secrete things into, or receive endocrine signaling and therefore need to have things leak into them. So they are the regions that are the exception to the rule. So, remember, pituitary gland, pineal gland, area postrema. Those are the big ones to know, unless you're going to be a neurophysiologist in endocrine signaling and the blood-brain barrier. You need to know your pituitary gland, your pineal gland, your area postrema, so the 3 Ps, right? If you know those, you know that the circumventricular organs, so they're around the ventricular system, are sampling the composition of bodily fluids to help modulate the endocrine system. So what about glial cells? Well, there are glial cells of the CNS and the PNS. And the PNS ones are satellite cells that wrap around the soma and Schwann cells that wrap around the axon. And the CNS, we can have macroglial cells, we can have microglial cells, and we can have ependymal cells. Now, our big glue cells, little glue cells. Big glue cells are astrocytes, star cells, and oligos. Right? Oligo means few because they're oligodendrocytes, so they're cells that have few dendrites. So if we start with macroglia, the astrocytes are either protoplasmic, which means they are grey matter ones, fibrous, white matter ones, or podocytic binding ones, which go to the blood vessels, like we said, to form that blood-brain barrier, or to help reinforce the pia mater. So there's 3 different types of astrocytes that we really care about here. Oligos, vascular ones, intravesicular, which help with the myelin formation. So you think oligodendrocytes, they're like the Schwann cells of the central nervous system. And then we have satellite cells as well. Now, astrocyte function, the 5 S's, this is how I remember it. They're a scaffold, They are scars, so they're involved in the glial scar. So after you have ischemia or any kind of damage, they will eventually come and encompass the region with the end feet and form a scar. Stasis, they're involved in homeostasis, so they wrap around things and they regulate the function of stuff. They're a sieve because they filter out things with the blood-brain barrier. Synapse clearance because they wrap around synapses, and at that synaptic bulb they remove all the debris and detritus and help with enzyme secretion and things. So those are the 5 S's that you could know about if you really care. Clinical correlation. So types of gliomas, you can have an ependymoma of the ependymal cells. These are the cells that line the ventricular system. Astrocytoma, including glioblastoma multiforme, which is this one, which is a horrendous tumour. Oligodendroglioma, or a mixed glioma. So it could be an oligoastrocytoma. How are they graded? They're graded 1 to 4. 3 and 4 are anaplastic. Okay, so GBM, that's the dishwasher. It's glioblastoma multiforme. It's the most common, it's the most aggressive glioma. Okay, so unfortunately, it's the most common, it's the worst. And you see that the glial cells are lesioned there with necrotic tissue surrounded by a ring of anaplastic cells. So here's your necrotic tissue and the ring of anaplastic cells. The incidence is 3 to 5 out of 100,000. Low-grade astrocytomas do occur in the 20s to 30s, oligodendrogliomas in the 40s, and GBM is more common over 55. So recently, Senator John McCain died of a GBM, and so did Ted Kennedy a few years before that. So, symptoms of the glioma, it's a space-occupying lesion, so it's all the signs that you'd expect, including speech and language problems, headache, nausea, visual disturbances. Don't forget papilloedema at end stage as well. Treatment, you debulk, combo radio and chemo, prognosis is dire. So the high-grade survival at 1 year is 30%, and at 2 years it's 14%. Mean survival for GBM is only 1 year. And I've got a few pictures there just to illustrate some glial cells. So there's the astrocytes, because they look like stars. Here, see if you can work out what this is. So this is, well, it says ol, so it's an oligodendrocyte. But anyway, this is the cell, and it wraps around different axons to provide myelin insulation. And here's a good example of astrocytes wrapping around capillaries and ependymal cells lining. Microglia are the white blood cells. And here's a few more examples. Connecting onto things. So, fantastic. Right, we'll quickly mention pathology of cerebral ischemia because it's not taught here at Warwick, but it's a core learning outcome. So when you have liquefactive necrosis, which is necrosis after ischemia within the brain, there are 5 different stages that occur. Within the first day, it's called a red one. So your eosinophils come in, the granulocytes come in, and they do their business. But within 3 days, the eosinophils are replaced with neutrophils. Now the microglia start to come in. Okay? You have reactive gliosis, which means that these glial cells are secreting loads of factors to cause blood vessels to come in here. So you get microbleeds because they grow really quick. It's like when you have wet age-related macular degeneration. And the VEGF and all the other factors cause the capillaries to grow too quickly, they have too much fenestrae, and they just leak blood everywhere. By 2 weeks, you've got the glial scar, which means that it's the remit of the astrocytes. Remember, that's one of the S's of astrocyte function. And then after 2 weeks, that's it. That's liquefactive necrosis, it's just a scar. So, another brief mention is postural hypertension, talking about the vasculature. So this is the fall of 20 milligrams of mercury in less than or equal to 3 minutes from standing. So your standing causes lower limb pooling of blood, which decreases venous return and has a transient decrease in cardiac output. So your blood vessel baroreceptors and atrial baroreceptors note all of this and trigger an increase in the sympathetic response to maintain cerebral perfusion. So if you're unable to compensate for this, so your sympathetic system is insufficient because of issues with cardiac work or autonomic dysregulation or hypovolemia, all these different kinds of functions, it's going to lead to cerebral lack of perfusion. Fall of 20 or more in less than 3 minutes, and you'll get postural hypotension. Can't compensate. Quick nod to cerebral aneurysms. So there's 3 different aneurysms that we'll mention, saccular and microsaccular. These are also called berry aneurysms because you have a blood vessel, and then you have a little cherry outpouching here. So this little saccular outpouching occurs. But you can also have them of the penetrating vessel. So remember ACAP, MCAP, PCAP? Well, these vessels, medial striate, lateral striate, and thalamogeniculate, if they get little pouchings, they're called microsaccular because they're tiny little penetrating vessels. But if it's not one little outpouching of deficit, but the whole thing is there, this is called a fusiform. It's the circumluminal, so the whole lumen causes that aneurysm. Now, when we look at incidence, you can see that the circle of Willis is some of the biggest culprits here. So here's PCOM, which is quite high, 25%. ACOM, quite high in the anterior cerebral artery region. Now note here, just before MCA divides into upper and lower arcades in the Sylvian fissure here, this has quite a high incidence as well. So ACOM, PCOM, and MCA, they're the 3 big ones. The pericallosal artery, which we've mentioned before, is also involved as well. And these are saccular aneurysms, remember? These little saccular bellies coming out. Bing. Right, so here are the anterior middle posterior cranial fossa. What's the blood supply to the dura? So the anterior meningeal artery, which comes off the ethmoid arteries. This one is the middle meningeal artery, which has anterior and posterior branches, remember? And the middle meningeal artery, which is injured in the pterion, which causes our epidural bleeds, comes off of the maxillary artery. And in the posterior cranial fossa, it's the posterior meningeal artery and some penetrating arteries. This comes from the ascending pharyngeal, which is actually a branch of the external carotid artery. So this comes off of the ethmoid, this comes off of the maxillary, this comes off of the external carotid ultimately. So that's the arterial supply of the dura mater, which lines the cranial fossae. So, in terms of the neural supply and the referral of which can cause headaches, okay, if in doubt it's V1. So this is from Graves. This is supposed to be colour coded. I think it looks really ugly, these colours. I'm not sure why they chose them. But this sort of, I don't know, would you call it lime green colour or something, is all V1. So you'll note the anterior cranial fossa is V1. The suprasellar region, the sellar region, and bits of the cavernous sinus is V1, as is the whole of the falx cerebri and the tentorium cerebelli over here. It's all V1. And then sort of lateral cavernous sinus and the midpoint of the sphenoid region, the middle cranial fossa, is V2. And V3 grabs the rest of it under here. And then your upper cervical ones are the posterior cranial fossa. So your anterior cranial fossa is V1. The sella turcica is V1. The middle portion of the middle of the MCF, the middle cranial fossa, is V2, and then the lateral portion of its wings are V3. Cervical region grabs the posterior cranial fossa, and our falx cerebri, our tentorium cerebelli, are still V1. So V1 arches and supplies all of these. So any irritation of these things will refer to those dermatomes. Okay, and here is another view just to demonstrate that this is all V1, all V1. This is cervical, this is V2, and then V3 out there. Quite useful to know, I think. So, ENT referred pain. Well, I made this little thing here back in first year, which sort of helped me to visualize it. So we have our external auditory meatus, we have our tympanic membrane, which is comprised of 3 different layers. Then we have our middle ear, we have our eustachian tube, then we have our nasopharynx, oropharynx, and laryngopharynx. So The external acoustic meatus is supplied by V3 or VC, the mandibular branch of the trigeminal nerve, and cranial nerve 10, which means that the outer layer of the tympanic membrane is supplied by the same stuff, so V3 and cranial nerve 10. Okay? But the inner portion is supplied by cranial nerve 9 because its neighbour, the middle ear, is supplied by cranial nerve 9. So V3, V3, 10, 10, 9, 9. What's 5? Oh, it's 9. What's 6? Oh, it's 9, but also VB or V2, the maxillary branch of trigeminal nerve, which sneaks on further here to supply most of the nasal cavity as well. Now the oropharynx is just cranial nerve 9, and the laryngopharynx is 9 and 10. Okay, so mandibular branch and 10, mandibular branch and 10, 9, 9, 9, maxillary branch and 9, just 9, so oropharynx, the afferent limb of the gag reflex is 9 if you remember, just 9, and then 9 and 10. All of this is sensory, which means infections, build-ups, growths, whatever you have in these regions will refer to those areas, okay? And I don't know why it's just done that. But there's your quick recap, okay? So just as part of the learning outcome as well, we mentioned the teeth and the paranasal sinuses, okay? So your teeth, the upper arcades are innervated by V2, or the maxillary branch, because they're in the maxilla. The lower arcades, the mandibular branch, or V3. So you could have some gingivitis in the gums of your lower arcade of teeth, and it would refer up to the external acoustic meatus. So you'd have outer ear pain because it's V3, it's referred. Paranasal sinuses are all innervated by the ophthalmic branch, with the exception of the maxillary paranasal sinus, which is innervated by, guess what, the maxillary nerve. Okay? There we go. So that is, I think, yep, that's the end of the lecture. So thank you very much. We are almost done, aren't we?